Cancer is basically a disease of the genome. 1914, it was first hypothesized that cancer came about due to chromosomal defects leading to abnormal cell proliferation. And in 1976, Bishop and Varmus at UCSF, everybody hear me okay? Is this one on or this one's on?
Both.
Both, okay. Published in Nature their seminal work on oncogenes showing that the pieces of DNA that we thought just existed in viruses that cause cancer was actually part of our normal DNA that then became altered and could cause cancer. Now, there are a multiple variety of different genetic problems that can give rise to cancer. One is what's known as a point mutation, where there's a substitution of one nucleotide for another. In this case, the arginine gets substituted for glycine, and GGT gets read as AGT, and adenosine gets substituted for guanine. And the genetic code, instead of being read out for glycine, the protein winds up with an arginine in that portion of the protein molecule. Therefore, a mutation in the gene leads to a mutated enzyme, and in some cases, such as the BRAF in melanoma, that leads to abnormal function that leads to cancer. There also can be a change in the number of copies of a gene. In breast cancer, there is increased numbers of the HER2 gene where it's amplified. There can also be translocations. In chronic myelogenous leukemia, there's a translocation between two chromosomes leading to an abnormal protein getting made where the break is spliced together, the BCR-ABL protein. Now, in chronic myelogenous leukemia, there's only one gene that's bad. In melanoma, there's an average melanoma cell has over 300 genes that's bad. So the question is, which of those 300 genes that are abnormal in your melanoma cell is important in driving the growth? So far, in cutaneous melanoma, we've identified 3 principal genes that drive abnormal growth that we can try and work and do something about. In ocular melanoma or uveal melanoma, that's more rare, really has entirely different molecular makeup, different mutation. Yeah, but in melanoma, 50% of cutaneous melanomas have a mutation in the BRAF gene. Usually it's a V600E mutation. The NRAS gene is mutated about 20%, and KIT at about 2%. And if you see the term wild type on the report, that means that there's the gene sequence that's discovered is the normal gene sequence. And that term comes from biology, referring to what you'd find in a wild animal. So this somewhat complicated slide shows the mitogen activated protein kinase pathway. Now, what I don't have, and I wish I had, is a picture that would show how the genetic abnormality leads to a protein being changed. And what these proteins are is they're large protein enzymes, and they control the chemical reactions inside the cell. And the key mutations are usually in the part of the enzyme called the activated site. And that leads to, frequently in the BRAF story, it leads to that enzyme being turned on all the time. And that leads to eventually the cellular proliferation. So here you have the nuclear membrane, and here you have the plasma membrane outside of the cell. And the green stripes represent the groups of proteins called receptors. And these proteins, they interact with growth factors that are floating around the bloodstream and floating past the cell. And when they're are affected by the right growth factor, they become activated. And then you have a whole stream of chemical reactions. So RAS interacts with RAF, and there's 3 forms of RAF, but the BRAF is what's important here. And if BRAF is mutated, what it does is that enzyme then activates the molecule called MEK, becomes activated phosphorylated MEK, which then activates ERK, and the activated form of ERK goes into the cell, and there it instructs the nucleus of the cell to start multiplying, dividing, doing bad things, behaving like a cancer cell. So if you have a mutation either in RAS or in RAF, that means this pathway is always turned on. Mutations in MEK are pretty rare, but do occasionally occur. We have found that different types of melanoma have a different incidence of these different 3 mutations. You can classify, well, forgetting ocular melanoma for a minute, because that's really a separate disease. You can classify other forms of melanoma in 4 different classes. One is that occurs in the chronic sun-damaged skin, such as the head and neck area, the arms, and that may be one of the reasons why it has a worse prognosis. Its genetic makeup is a little bit different, has lower incidence of the BRAF mutations. Non-chronic sun-damaged skin is skin on the trunk or thighs. Here we think that probably acute sun exposure, sunburns as a child or adolescent, what leads to the mutations. They have a higher incidence of the BRAF and RAS mutations. Now the KIT mutations occur mostly in mucosal melanomas or melanomas on the hands and foot, palms and soles, in areas really where the sun doesn't shine. So it was really only about 12 years ago that it was first described the BRAF mutation V600E present in about 50% of all cutaneous melanomas. 8% of all human cancers have the same exact molecular mutation. And this is a enzyme in that pathway I described. We now have 2 FDA-approved pills that are treatment for it. These pills work by being small molecules that get into the activated site of the mutant BRAF and stop the activity of that mutant BRAF. Now, unlike, say, chemotherapy that sort of attacks all sorts of proteins and DNA in your cells, these pills, by and large, just affect that mutant enzyme, which is different than any normal enzyme in your body or anybody else's body. So what we see is very remarkable. In era of chemotherapy, we saw improvement only in 5 to 15% of patients when you gave them a drug. Here, with targeted therapy, we see improvement in 80% of patients. The toxicity is lower than what we saw with chemotherapy. However, the median duration of response, how long the improvement lasts, unfortunately, is only about 6 months. Because melanoma has 300 mutations, and we're not in the situation, for example, targeted therapy for chronic myelogenous leukemia, you've only got 1 molecular target. When targeted therapy was invented for that disease, the mortality rate went from 20% a year to less than 1% a year. And people, instead of it being a death sentence, they live for decades and decades and decades. We'd like to achieve that with melanoma, but we haven't yet. So this shows the derivation of the name vemurafenib. The Zelboraf and Finlarg are the brand names that are supposed to be easier to remember and pronounce. Sometimes they aren't, actually. So this shows another way of looking at the pathway where RAS interacts with the BRAF, and if BRAF is mutated, it drives gene transcription with excessive proliferation. And the drug Zelboraf, or also known by the generic name vemurafenib, blocks the enzyme, the proliferation at this point. And the controlled phase 3 trial, when they compared it to dacarbazine DTIC chemotherapy, the chemotherapy slowed down the tumor not much at all. Most of the patients at 1.5 months, which is when they got their first follow-up scan on the trial, were found to have progressive disease. But with vemurafenib, the median progressive survival was tripled to 5.3 months. And the trial of dabrafenib came along with a trial about 6 months to a year later. The exact same design, really, DTIC, you see the curve, it falls off pretty quickly. The progression-free survival in dabrafenib, similarly, 5 to 6 months. Now, the overall survival is improved with the vemurafenib over dacarbazine. In this trial, the patients that got the dacarbazine, it had a crossover design, which meant that after they had shown that the tumor was growing on the DTIC, the dacarbazine, they got to cross over and get the vemurafenib. Despite this, the overall survival was statistically significantly better with the vemurafenib. But you unfortunately don't really see any tail on the survival curve here. It just keeps going, going, going. Now, these drugs have only been around a couple years. I think the first clinical trials were started 4 years ago. And there are a few patients that were started on these drugs 4 years ago that are still doing well without relapse. But the vast majority of patients have relapse. Now, there are some funny side effects with this class of BRAF drugs. One of it is that patients get keratoses or low-grade skin cancers while they're on treatment for cancer. And the molecular biology of that seems to be that some of the patients carry an HRAS mutation in some of their skin cells, and then when you block BRAF, you may stimulate ARAF in any way. Clinically, it's not a big problem because these are not aggressive tumors. They don't metastasize. They're just really a cosmetic problem and can be easily removed and rarely recur after local surgical removal. The dabrafenib was FDA approved this year. Vemurafenib was FDA approved 2 years ago. The toxicity is similar, and as I said, the efficacy is similar. But it does have some advantages. Less photosensitivity. Patients on vemurafenib, if they live in Texas or Arizona, they get a sunburn walking from their car across the parking lot into the doctor's office. Literally, their skin becomes that sensitive to the sun. Less arthralgias. Fewer patients have to have the dose reduced because of side effects. But they do get more frequent drug fevers, which can be upsetting and alarming, but the fevers usually go away if you stop the drug, and usually don't recur. So we've talked about BRAF drugs. What about the next? The next step in the pathway is the enzyme called MEK. And MEK, as I said, mutations are not common in the MEK enzyme, but this pathway is really not important for normal cells very much, so that a drug that blocks the activity of the MEK enzyme would also help with patients that had RAS or BRAF mutations. And the BRAF mutations, as I said, are about 50% of melanoma, also in thyroid cancer, ovarian cancer, some colon cancers. RAS mutations are actually even more common in human cancer. It's present in about 20% of melanoma patients, but present in a high incidence in pancreatic, lung, and colon cancer. So there's actually more than 3 MEK inhibitors under study, but I'm just going to talk about studies involved the 3. I think, fortunately, no one drug company has a patent on making a drug to block MEK. So there's actually a pretty good competition going on between the drug studies to get the drugs to market and to figure out the best way to use them. The first one, trametinib, was FDA approved 4 months ago. Now it's FDA approved for the BRAF mutations. It's actually not being heavily marketed because it's probably not as good as dabrafenib for when used alone as a single drug. The MEK 162 is made by Novartis. It's in trials for NRAS mutations, and the selumetinib is involved in trials with ocular melanoma as well as other cancers. So this was a phase 3 trial of the first of the MEK inhibitors, the trametinib, comparing it to chemotherapy for patients with BRAF mutations. And patients were randomized. 66% got the trametinib, a third got the chemotherapy, and if the ones that got chemotherapy had a crossover to trametinib if their cancers got worse, or when their cancers got worse. The side effects of this drug are not too bad. This chart does not include what we say are mild side effects, grade 1 and grade 2. But 12% had grade 3 hypertension, which is actually only hypertension that you need to take a pill for. The grading there, although most grade 3 toxicities the patient feels pretty bad with, like a grade 3 rash is a really, really bad rash. Grade 3 hypertension, actually the patient feels fine, the doctor just has to give them a prescription for a new medication. But patients do get fatigue, itching, some liver enzymes, anemia, the things that you get with the chemotherapy were not seen with the MEK inhibitors. And the progression-free survival, the chemotherapy arm came out at 1.5 months, just like all the other studies. The trametinib, you're out 4.5 months with disease control. The rate of improvement is a little, and the survival also was better. Again, even with the crossover, the patients who started on the chemotherapy were a little bit behind the 8 ball in terms of survival. And this, okay, this is the some of the data from the other MEK inhibitor, the MEK 162 made by Novartis. And what this graph does, the 0 is the basically the size of their tumors when they started the treatment. And the lines that go down are the patients that had a high percentage of tumor shrinkage. And the lines that go up show patients that never had any tumor shrinkage and had all that was seen was tumor growth. As you can see, most of the patients had some tumor shrinkage. About a third of the patients had enough tumor shrinkage. The dotted line is the 30% shrinkage, which is by definition what we call the partial response by RECIST criteria. And similar data are available for the trametinib. Now, the MEK 162 was tried in phase 2 trial, both on the, I just showed you the data against BRAF mutations. 23% of patients had excellent tumor shrinkage. But they also tried a very small study, 30 patients, against the NRAS mutation, and they saw shrinkage in 21%, which is, although it's a very small study, significant because there's really never been any drug before that's been able to target RAS mutations. So this has to be confirmed, and in a larger study that is going on to confirm this, but this would be significant. And this is another chart showing the that severe side effects were pretty unusual in most things. Patients with MEK inhibitors do get some eye toxicity. They can get, something called central serous retinopathy that is reversible, usually mild grade. They can also see sort of funny lights that last for a few seconds. Those are also reversible. But by and large, it's pretty well tolerated drugs. Now, this shows the pathway that we think is important in ocular melanoma. The ocular melanoma doesn't have RAF or RAS or MEK mutations. It has mutations way up here in an enzyme called GNAQ. And we think that that drives through several different things, eventually can get down and drive this ERK pathway. And so there was a study done with selumetinib comparing this MEK inhibitor, and I don't know why they have the MET instead of MEK. in the middle of the name. It's so bizarre because there's another pathway that involves something called MET, so it's actually very confusing. Comparing temozolomide, as you can see with the usual chemotherapy, you only had 3 out of all these patients that showed any tumor shrinkage at all. But with the selumetinib, there was evidence of some shrinkage in about 50% of patients, and a good 15% showed very excellent tumor shrinkage. And the data also showed that the progression-free survival appeared better with the selumetinib than with chemotherapy. The difference was not enough to be statistically significant with overall survival. But studies with selumetinib in ocular melanoma are ongoing, and it's probably going to be the first drug that's ever FDA approved for ocular, well, the second drug that's FDA approved for ocular melanoma. Ipilimumab is FDA approved, but there was never actually, that approval strangely doesn't rest on a good study of ipilimumab in ocular melanoma. It was just sort of that they sort of said the word melanoma and didn't qualify it when the FDA wrote the approval. So what about combining these two therapies? Well, in some other diseases and some other targets, when you combine 2 inhibitors on the same pathway, and I'm thinking of Avastin and VEGF inhibitors in renal cell, you just get horrendous toxicity. But the interesting thing is that these 2 types of agents have been able to be combined without horrendous toxicity. In fact, probably with somewhat a decrease in toxicity. There's certainly a lot of rationale. You're blocking the same pathway at 2 different points, and hopefully it'll improve the time in which it takes for the disease to become resistant to your treatment. So let's talk a bit about what might be going on after 6 months on a BRAF inhibitor to cause resistance. Now this is a big subject of ongoing research, but basically you might be getting a new mutation, or a mutation may be coming out in NRAS that then could go through something called CRAF. You're usually not finding too much any new mutations in the BRAF. You might get a mutation in MEK, you might get overexpression here, you might get a whole different pathway going. But unfortunately what we are seeing is that the patients that become resistant to the BRAF drugs, there can be accelerated tumor growth, especially if you stop the BRAF drug, because then the patient's tumor has not only this pathway to grow, but it's got another pathway that's pushing tumor growth. So let's talk about combining our BRAF and our MEK drugs. And patient characteristics on this study, which was done by using the 2 Glaxo drugs that were FDA approved, 90% of patients are V600E mutations, 10% are V600K. The BRAF drugs, we have good data on dabrafenib. We actually don't have very good data on vemurafenib in distinguishing between the activity against V600E and V600K, because the assay they did on the vemurafenib study didn't do a good job in distinguishing which they were dealing with. But the BRAF drugs do a better job, it seems, with a V600E than they do the V600K. And you can sort of understand that because the drug is really fitting into the part of the enzyme where that mutation is. And so with a different amino acid sitting there, it might not fit quite as well. So let's take a look at the toxicity. Well, again, we're sort of ignoring the milder toxicities of grade 1 and 2. 8% had fevers. Severe rashes were no longer seen. Somehow the BRAF calms down the rash that MEK makes. You do see chills, fatigue, nausea. You also see fewer of the skin cancers that you saw. And the response rate, you're getting a response rate again, 57%. You're seeing, it looks like you're seeing more patients with complete disappearance of all tumor. And instead of getting progression-free survival limited to 6 months, it's going out to 11 months. So you're getting longer control of the cancer using the two drugs together without any additional toxicity. And this data actually is being presented to the FDA, and supposedly the FDA on January 10th is going to make a decision about whether to approve both being used together. The response rate, taking a look at the BRAF naive is the patients that hadn't had BRAF treatment yet. And here you see total 67 plus 9, you have 75%, 76% response rate, just really excellent. Nobody that had cancer growth in the first few months. Amazing amount of activity. Now, if they had already been on the BRAF drug and you just added the MEK drug, the responses weren't as good. About 15% was all. And some patients just kept right on progressing on that. So it would appear the best strategy, at least as soon as it gets FDA approved, is to use both drugs at once. And this shows that using both drugs at once, your progression-free survival is out here 10 months, and it's not really very good if you've already resistant to the BRAF. And this shows the maximum tumor regression. You have patients that have complete responses. You have virtually nobody that shows only tumor growth. However, if they've already had the BRAF and been growing on BRAF, you have fewer patients that get the tumor shrinkage you want. So looking across sort of 4 different treatments, chemotherapy, vemurafenib, dabrafenib, and the combination dabrafenib and trametinib, you see that you get improvement in progression-free survival, 11 months with both together, improvement of response rate up to 76%, median duration of response is longer. We don't have good data on survival yet. And some of the toxicities, the grade 3 rash seems to be less on the combination, skin cancer is less. So let's, I think we've got a minute to talk about one of the other mutations. KIT mutations are much more rare in melanoma. One of my things I published a study on a year ago. KIT is an enzyme that's on the surface of the tumor cell. And it's the thing that's floating around to turn it on is called stem cell factor. So you might imagine that if KIT gets turned on, then the cell starts to grow. KIT mutations are present in about 80% of a completely unrelated cancer called gastrointestinal stromal tumors. And the same mutations can be seen in patients with acral or mucosal melanomas in about 20% of cases. And unlike BRAF situation where it's the same mutation in all cases, there's a variety of different KIT mutations that cause that activation. And there are now actually at least 4 drugs that are FDA approved. The first 2 are FDA approved for the gastrointestinal stromal tumors. Sunitinib that I studied will soon become generic, that inhibit mutant KIT enzymes. And this is the table that shows the results of 90 patients that we tested for different mutations. Mostly mucosal, we found 17% had KIT mutations, acral 14%, chronic sun damaged skin we had 5%. The non-chronic sun damaged skin we did not test, but probably would be far less than 1%. Nobody had the GNAQ mutations because those are seen in ocular melanoma. And this, we had 3 or 4 patients had a good response. This is a woman that had, you can see on her PET scan, 2 metastases in her liver after a year of treatment with sunitinib. She had persistent complete response. Unfortunately, 6 months later, disease came back and she eventually died. But she had excellent control of disease for over a year. with the sunitinib therapy. So we saw responses in 3 or 4 patients. We also found that KIT mutations were a bad prognostic factor. Of the 90 patients, when you lumped them together, the ones that had KIT mutations only lived about half as long as the ones that didn't have KIT mutations. And one of the patients, when he relapsed, we found a mutation in the NRAS gene, which we hadn't found on his original biopsy. So one of the questions is, what's best to start with? Since there's no FDA-approved regimen for using immunotherapy with targeted therapy, which do you start with? The best response rates with the BRAF therapy. And on the other hand, durable remissions are what you see with immunotherapy, with ipilimumab. And it's not clear that the BRAF therapy really gives a very large number of durable remissions at all. We also find that if you start with melanoma with the BRAF therapy and you just continue that, by the time they start growing from the BRAF therapy, they may have very rapidly growing melanoma that won't be responsive to the addition of MEK therapy or to the addition of immunotherapy. So even though if you polled 100 oncologists in America, what would you treat first if a patient had melanoma with BRAF mutation? And 90 would say, oh, I would just give the BRAF drug. That's what they find from market surveys. Probably, unless the patient has rapidly progressive disease, they should be treated with immunotherapy first. Or, of course, if you have available protocols combining immunotherapy with targeted therapy. So, targeted therapy, Jim Allison, who really is responsible for the development of ipilimumab, immunotherapy, made these slides. Targeted therapy and chemotherapy, really great at improving the problem of early deaths from cancer, stage 4 cancer. And you get improvement there, but the tail of the curve doesn't seem to be affected very much. If you give somebody immunotherapy like ipilimumab, you know, at the beginning, the survival isn't improved very much. But then you've got this tail on the curve that's very nice. So what we're hoping to do with combining them is get a survival curve that looks like this. And so what's being done on immunotherapy with BRAF therapy together? Well, the first official, and only actually published official trial of vemurafenib and ipilimumab. Unfortunately, the companies couldn't get it together to start the trial until both drugs were FDA approved in 2011. And you know, neither drug company wanted to, you know, start with a low dose. And as they started with a 75 to 100% dosing of vemurafenib, they stopped the trial after 10 patients because of excessive liver toxicity. And I suspect, I hope none of you are from Genentech or Roche, I don't know, that, well, I'll say Roche corporate interest didn't want to find out that a 25% or 50% dose of vemurafenib would work fine. The reality is that in the phase 1 trials, they had good responses at a much lower dose. But of course, that would decrease the sales if they found out that you only needed a much lower dose. But I don't think that's going to be a permanent problem in the treatment of melanoma. Because my own prejudice is that dabrafenib is a better BRAF inhibitor. And Dr. Amita, I know, has entered patients on the phase 1-2 trial of dabrafenib and trametinib that was open this spring. And so far, it continues with no intolerable toxicity being found. Now, in the last 2 years, there's a lot of patients that have received either vemurafenib first and then ipilimumab, or ipilimumab first and then vemurafenib. And the patients that got ipilimumab followed by vemurafenib, some of them got very severe rashes. And this is a case I published, really Stevens-Johnson syndrome, when the vemurafenib was given after ipilimumab. Patients subsequently received desensitization to the vemurafenib and was able to tolerate it. So this is a list of the clinical trials we have available, both for stage 3 patients using immunotherapy or targeted therapy. We have first line a trial that involves ipilimumab immunotherapy and anti-PD-1, and we're going to also be opening a MEK inhibitor for the NRAS mutated melanomas. And I think, yeah, the cure is going to involve not only surgery, targeted therapy, immunotherapy, perhaps anti-angiogenic therapy. I want to thank these individuals, also American Society of Clinical Oncology, that actually on their what's called ASCO University website places most of these slides, and that I was able to borrow. And I'll stop now. Thank you.